So, welcoming you all to the sixth session of our foundation course in palliative medicine. Today, our focus of discussion would be on difficult pain. And we have the eminent faculty, Dr. Mary Abraham, joining us back to walk us through the session. Even though she is already introduced to this batch, I would just take you through her profile once more. She is the visiting consultant of the Max Group of Hospitals in New Delhi, and her main areas of interest are neuroanesthesia, pain and palliative care. And she has also been awarded the Lifetime Achievement Award by the Delhi Neurological Association. And she has authored a book, Conquering Pain, in 2019, which is a very good reference readable for the medical professionals. So without much delay, Dr. Mary, it is over to you for enlightening us on the difficult pain.
Sorry. Okay, thank you so much for that introduction. And now we move on to the management of difficult pain. Now, can I share the screen?
Yes, ma'am.
Okay. Okay. So now it's clear now. I mean, it's come on, right? Okay. So here we go. Just to recapitulate, by now you would have been talked to about the WHO step 3 also, in addition to the step 1 and step 2. So very useful tool to manage cancer pain, but unfortunately, 71 to 76% only can have good relief with this 3-step ladder. So there is about remaining about 15 to 20 plus patients who may not respond even to strong opioids. And that is when it is called refractory cancer pain. So there are other terminologies. The other synonyms for refractory or difficult cancer pain are intractable pain, persistent pain, or opioid non-responsive pain. So what is the definition of this? It is pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. What are the risk factors for developing intractable cancer pain? Patients who are young are more predisposed to get intractable pain. Neuropathic pain is quite difficult to treat. Incident pain, cancer pain can be both continuous as well as incident, right? Incident is when doing any activity or movement can suddenly cause a spike of pain. That's more difficult to treat. Also, when they have psychological distress, previous opioid use, tolerance to opioids, history of addiction, and impaired cognition. So these are some of the risk factors why people develop intractable cancer pain. So let me start the discussion by a case scenario. This was a 62-year-old man, CA rectum, with peritoneal and liver metastasis. He was on chemotherapy since 1 year. Initially, he responded to the chemotherapy, but 1 year later, he had a recurrence of the cancer, and one day he developed acute intestinal obstruction with pain in the abdomen due to progression of the primary lesion. Now, because of the acute intestinal obstruction, he was taken to the ER and admitted for conservative management of this. A Rice tube was inserted and a colostomy was done. And he was discharged with the advice of continuing with palliative care. They did not want to do anything major because the cancer had spread and he also had liver metastasis and he was also very emaciated. So they didn't want to do any major surgery. They just did a colostomy and put in a Rice tube. So initially at home, he was taking the WHO step 1 and step 2 to the nasogastric tube, along with adjuvants for the pain abdomen. But the pain persisted, and then he had to be started on step 3 drugs also. One day, he pulled out his Rice tube and he did not want it inserted because in the first place itself, he did not want a Rice tube. And now he very categorically indicated that he did not want the Rice tube inserted. Now, this was a family was faced with a dilemma, because how do we feed him? How do we give him his oral drugs? He was extremely emaciated and weak. So it was easy to put in a rice tube because he was so weak, that it was not a problem putting in a rice tube. But because of the patient's wishes, it was decided that we should respect his wishes, and we decided not to reinsert the rice tube. And this is what is called patient autonomy. That is, the patient's wishes were taken into consideration while taking this decision. So, because he also had a chemo port, we decided to start him on maintenance IV fluids. But the pain grew worse, and then he had to be switched on to transdermal fentanyl patch, 25 mics per hour, along with uh, oral transmucosal fentanyl citrate, that is the fentanyl lollipops of 200 mics SOS. But there was no relief, and he was in agonizing pain, and he was in fact shouting with pain. The family was extremely distressed. So what do we do next? Okay, now we'll come back to this at the end of the presentation. See, how do we manage this kind of patient? So when we look at the steps for the management of difficult pain, the first important thing is to review the patient's condition. And then we have to manage it both by pharmacological as well as by non-pharmacological methods. The pharmacological methods include route conversion, route rotation, or using adjuvant drugs. And the non-pharmacological methods includes interventional pain management, psychological therapy, physical therapy, alternate therapy, spiritual therapy. So you see that there is a multimodal, multidisciplinary management that now comes into play. Okay, with so many specialists involved in this management. So let's look at the step 1, that is review the patient. So a useful mnemonic is ABC, 2 C's in fact. The first is he adhering to the treatment? The second is, we should believe the patient when he has pain. This gentleman was screaming with pain. So we had to believe that he had severe pain. As Margot McAfee in 1968 aptly said, pain is whatever the experiencing patient says is existing whenever he or she says it does. So in simple terms, pain is what the patient says hurts. Okay, we cannot add or subtract what the patient is saying. And the next C we should know is comprehensive pain assessment needs to be done, which has already been talked about earlier. We look at the pain characteristics, we look at the functional history of the patient, we review the previous drug history and the non-drug history, and we examine the patient and again review the patient. And the next C is correct the correctable factors. Is there anything that needs correction? Like maybe if there's a pleural effusion or an ascites, maybe that needs to be tapped to relieve the pain. Or is there an underlying secondary infection? Is there insomnia, anxiety, nutritional status, etc.? So we need to do that also. Now, checking adherence to the treatment. For that, we need to review the analgesics that the patient is taking. We need to review the adjuvants. We should check the patient's understanding of the dosing regime, and we can use teach back techniques. What are we prescribing? Are they following that meticulously? Because sometimes the normal tendency is that only when the patient has pain will they give the drug. That is a normal tendency. They feel that we are overdosing. But we have to explain very categorically that when we write paracetamol 3 times a day, it has to be given 3 times a day. Even if the pain is not there, you have to repeat it. Similarly, morphine. If it's 10 milligram Q4H with SOS doses to treat the breakthrough pain, then we have to give it like that. So a useful thing is to tell them to read it back, teach back techniques. You ask them that, tell me how are you giving the drugs, and see whether it is according to what you have prescribed. Okay. That is called teach back techniques. By this, we'll come to know whether the prescription that we have written is being followed or not. Because many a time, it is because of not following the prescription that the patient is having the pain. So we should first rule that out. Now, there are many reasons for opioid ineffectiveness. because I said it is not responding to step 3 drugs. So why is it ineffective? The common causes are accumulation of toxic metabolites, as a result of which there are intolerable side effects like neurotoxicity, sedation, delirium, hyperalgesia, myoclonus. So these toxic metabolites are not allowing you to escalate the dose because of the side effects. Another very common reason is progression of the disease. Has the disease progressed more, and that is why he's having so much of pain? Or is there a new pain type that has now occurred, which was not there before? For example, is there a bowel obstruction pain, or is there a spasticity, or is there a neuropathic element? Then we have to add appropriate adjuvants. Then, is the route of administration that we are giving not effective? For example, if a patient has intestinal obstruction, the oral route will not work, right? So, or sometimes the transdermal absorption may not be taking place. Or there could be, if there's an IV or a subcutaneous or a spinal opioids being given, is there a malfunction of the catheter? Or is there a misplacement of the catheter, pump, or needle, or something that has gone wrong with the system? And very important is, are there psychological, social, or spiritual factors that have come into play? So I mentioned about the pharmacological and non-pharmacological treatment. So let's first focus on the pharmacological options for difficult cancer treatment. The first is opioid manipulation. We may have to do some jugglery with the opioids. That could be in the form of either a route conversion or a switch, opioid switch, we call it. I'll talk about it later. And the second is whether we need to add some adjuvants like antidepressants, anticonvulsants, which are all mentioned earlier, which I've talked about in my previous talk. Now coming to the route conversion. Now in route conversion, the same opioid is given, but in a different route of administration. For example, if the patient was taking oral morphine, do we need to move on to an IV morphine because of lack of absorption? Or if the patient is on a transdermal fentanyl patch, do we need to change it to an IV or a subcutaneous fentanyl? Now, high serum concentrations of these drugs can be achieved by both IV and the subcutaneous route. Means adequate serum concentrations can be achieved. And both morphine and fentanyl can be given intravenously as well as subcutaneously. But just remember the conversion factor from oral to subcutaneous to intravenous morphine is 3:2:1. That is 30 mg oral morphine is equivalent to 20 milligrams of subcutaneous and 10 mg of IV morphine. So that ratio, we should keep it in mind. Now, this IV opioids, if you're switching over to IV opioids, that's called a route conversion. It can be for continuous pain, you can give it as a continuous basal infusion. But if the patient has an incident or breakthrough pain, then we can add an intermittent bolus as well. So for patient-controlled analgesia, we have various devices that are available. We can give a basal infusion, which will take care of the continuous pain, and we can give a bolus for the incident pain, which can be controlled by the patient. That is why it's called PCA, or patient-controlled analgesia. So there's a remote that the patient can have, which is seen here. And this is the disposable elastomeric pumps, in which morphine is filled over here and it's attached to the patient, and they have a remote in the hand for the intermittent doses. Or you have the other system, which is called the continuous ambulatory drug delivery, or the CADD pump. This also has a remote, which is not shown here. So this can take care of both the continuous pain as well as the intermittent pain, breakthrough pain. Now, there is no evidence of the superiority of parenteral versus oral opioids to control intractable cancer pain. But the European Association of Palliative Care does recommend the use of parenteral opioid infusions in case where oral or transdermal opioids have failed to provide effective analgesia. Now, the next way of manipulating opioids is by doing an opioid rotation, or which is called an opioid switch. That means you're using the same route, but a different opioid. For example, you're giving orally morphine, now you give oral methadone. Now, what are the indications for opioid rotation? First of all, when there is an intolerable side effects from opioid, from the oral morphine, that is because of the neurotoxicity, or there is a poor analgesia despite titrating the drug. How does it work? It works by incomplete cross tolerance. So in incomplete cross tolerance, some receptors are still there which are amenable to action by the methadone, and all are not blocked. So that is how it works because of incomplete cross tolerance, and you can get greater than anticipated potency with another opioid drug. Now, when you're doing an opioid rotation, we have to convert, like I said, one opioid to another. So there are 3 steps in this whole thing, which I think must have been discussed in your previous talk, but I just once again go through it. So we need to know the equianalgesic table to find the equianalgesic dose, or what is called the oral morphine equivalent, or OME. For example, we know that 25 mics per hour fentanyl patch is equivalent to 60 mg morphine per day. So based on that, you can convert into the fentanyl patch. If the patient is on oral morphine, then you can convert into the fentanyl. So once you calculate the equianalgesic dose, then because of the cross tolerance, we need to reduce it. The final dose that you're giving, you have to reduce it by 50% if the patient is having well-controlled pain. But poorly controlled pain, you have to reduce it by only 25% after calculating the oral morphine equivalent. But the exception to this reduction is methadone. I'll talk about it later. In addition to that, you have to also prescribe a rescue dose. So what are the indications? So we know that one of the common effects of morphine, the side effects are sedation, delirium, myoclonus, hallucinations, hyperalgesia, seizures. And the cause of that is because of the metabolites morphine 3-glucuronide and normeperidine. So that is a cause of the neurotoxicity, because of which you need to do the opioid rotation. So in India, the other opioids that are available in lieu of morphine are methadone and fentanyl. Okay? These are the only other strong opioids that are available in India. Now, methadone is inexpensive, can be given orally, but both are under the same legal control as morphine. So that we have to keep it in mind. Now, what about methadone? It must have been talked in the earlier talk, but nevertheless, I'll just talk about its advantages. It is very potent. It is, in addition to nociceptive pain, it is very effective for neuropathic pain because it also acts on the NMDA receptors, as well as it is a serotonin norepinephrine receptor inhibitor. So it acts on the descending inhibitory pain pathway. It does not have any active metabolites. It has a long half-life of 8 to 12 hours. It is slowly eliminated, so reduces the risk of breakthrough pain. It does not accumulate in renal impairment. Less tendency for tolerance and no cross tolerance with other opioids. And it's also relatively inexpensive. But the disadvantages are that there is a risk of life-threatening ventricular arrhythmia, particularly if the QTC is prolonged on the ECG. And this arrhythmia is called torsades de Pontis. So titration is also difficult, and there could be a risk of overdose because the half-life of this drug is variable, and it has to be given only by experienced palliative care specialists and not by the novice in palliative care. So the indications of methadone are, first of all, like I said, for opioid rotation. And also, the cost-wise, it's the least expensive of the long-acting opioid drugs. It is given when there's a true morphine allergy. In neuropathic pain, because of it, I told you it is effective for neuropathic pain, and also when there's renal dysfunction. But there are contraindications which you should keep in mind when there are ECG changes and QTC prolongation, then there's no reliable caregiver, then there's a history of sudden unexplained death in the family, There could be some cardiac issues, then you avoid it. And also the drug-drug interactions, particularly with azithromycin, fluconazole, and amitriptyline. So when you're converting from morphine to methadone, this is a useful conversion table. When you're giving less than 60 milligram of oral morphine a day, then the oral morphine equivalent of methadone is 2 to 7.5 mg per day. If the patient is already getting between 60 to 199 morphine, oral morphine, and the patient is less than 65 years of age, then the conversion is 10:1. For example, if the patient is getting 100 mg morphine, then you divide it by 10, that means 10 mg of methadone. If the patient is getting more than 200 oral morphine equivalents, then, or if the patient is more than 65 years of age, then you have to divide it by 20. For example, if the patient is getting 200 mg of morphine, then you have divided by 20, that is equivalent to 10 mg of methadone. Now, methadone is available as 5 milligram tablets, and the syrup is 5 mg per ml. So as per expert consensus white paper, the equianalytic dose suggested for methadone are very conservative, and we need not account for incomplete force tolerance. That means we need not reduce the dose like we do for the other opioids. Okay, that can be kept in mind. Now, the other drug that can be used for difficult pain is buprenorphine. So this is another option for opioid rotation. It can give better pain relief, good tolerability. It can control neuropathic pain and breakthrough pain better. Transdermal route, we have patches available. The Buvalor patches, that is a trade name. It comes in various strengths, 2.5 mics per hour, 5 mics per hour, 10 mics per hour, and 20 mics per hour. And each patch, it lasts for about 7 days. Now, sublingual tablets or sublingual films are available, which are of 200 mics each. The effect lasts for 6 hours and is especially useful for breakthrough pain. So when you want to convert morphine to buprenorphine, if the patient is getting less than 30 milligram per day, then you can start with a 5 mic per hour patch. If the patient is getting between 30 to 80 milligrams of morphine per day, then you can give a 10 mic patch. And if there is a breakthrough pain, then you can give an immediate release or a non-opioid analgesic as well. But if the patient is on more than 80 mg oral morphine, then a 20 mics per patch may not suffice. So we have to think of other ways of handling that. Now, breakthrough pain in cancer. Now, breakthrough pain is intermittent episodes of extreme pain which breaks through the opioid regime that the patient is on. This can occur spontaneously, or more commonly is caused by movement of an affected limb or bearing weight on a tumor-bearing bone, or sometimes even breathing, when there is a rib metastasis, then it can cause, even breathing can cause breakthrough pain. The incidence of breakthrough pain is pretty high. It is around 40 to 80%. And for that, how to treat it? We need to give a fast-acting, short-duration opioid. Okay. And for that, options available are either you give an immediate release morphine, or you can give oral transmucosal fentanyl citrate. That is called OTFC, or a fentanyl lollipop. They come in strengths of 200 mics or 400 mics. So it not more than 4 should be taken per day. It should be sucked over 15 minutes and not chewed. And the effect starts in 30 minutes and lasts for 2 to 3 hours. Alternatively, you can use sublingual buprenorphine 200 mics also to treat breakthrough pain. Having reviewed the cause, again, we have to see whether the pain is nociceptive or neuropathic. Is there any need for an adjuvant drug also? So this I have talked about. What is nociceptive pain, which is at the peripheral nerve ending. Anything beyond that is a neuropathic pain. So we have to see whether the patient is having a nociceptive pain, a neuropathic pain, or a mixed type of pain. Now, ketamine is one drug that can be used to treat the neuropathic pain, particularly when it's difficult pain. Like I said earlier, it acts at the NMDA receptor in the dorsal horn of the spinal cord and the thalamus, and they can be used when they are unresponsive to the antidepressants and anticonvulsants, which is the first line treatment of neuropathic pain. It can be given through a variety of routes, but I just want to talk about the burst ketamine, which I will talk because that is what is done for difficult pain. So burst ketamine or a pulse course of ketamine is given for a maximum of 5 days using a syringe pump, and it is generally done in a hospital setting with monitoring. So you start off with 100 milligrams per day and over a period of 24 hours, and you give it for 3 days. If it is not effective, then you can increase it to 300 milligram in 24 hours and give it for 3 days. If that is not effective, you can go up to 500 milligram per 24 hours. And if that is not effective, then we have to stop it. This is what is called the pulse course of ketamine. So this has been used where standard analgesic options have failed, and it can be used as a reasonable third line option to treat neuropathic pain. Now, these are the side effects of ketamine, which I've already discussed in my earlier presentation. The other drug that is used for difficult neuropathic pain is local anesthetics. So they act by decreasing the neuronal excitability at the level of the calcium channel, and it is used for severe intractable crescendo kind of neuropathic pain. So this is how you give it. You add 5 milligram per kg, calculate it and add it in 500 ml of normal saline and give it over a period of 1 hour, along with cardiac monitoring and also monitoring for the CNS side effects of local anesthetic. This can be repeated out for a few days again, and this you can do to arrest the very severe neuropathic pain. We can also use topical local anesthetics like lidocaine patches, which are now available in India. I talked about in my last session. And the other topical agents to treat neuropathic pain are topical capsaicin, 8%. Now it is available. I said it's not freely available, but recently I think it is available in India. Because in a recent pain conference, we were all given samples of capsaicin patches. Topical gabapentin can also be used to treat neuropathic pain. So once again, I've shown this earlier, but the way you treat neuropathic pain, the first line treatment is amitriptyline and the gabapentinoids. Then you can also use duloxetine and lidocaine patch. And the second line treatment are opioids and tramadol. And the third line, this is what you use for difficult pain, could be capsaicin, ketamine, and cannabinoids. So let's talk about cannabinoids in difficult pain. We all know that cannabinoids has been used for various ailments since ancient times. But in medicine, the use has been restricted because of the legal and social concerns due to drug misuse and abuse. But a few symptoms in cancer can be resistant to the current palliative care treatment options. So, but despite the absence of robust clinical data, that it has a definite favorable risk, still it is not yet routinely recommended for palliative care treatment, but still it has now been used for palliative care. Now, cannabinoids, how do they act? They act on two receptors in the brain, that is CB1 and CB2. The CB1 receptors are found in the brain, spinal cord, peripheral nerves, and they're poorly expressed in the brainstem, and that is why there's a low incidence of respiratory depression with cannabinoids. And the CB1 receptors are the ones that mediate the well-known psychotomimetic effects of cannabinoids. That is the delirium and the euphoria that these people experience. But the CB2 receptors are mainly found in the immune system. It does not have psychotomimetic effects, and they are being investigated for their therapeutic effects, namely the analgesic, anti-inflammatory, and even anti-neoplastic effects. That is because of the action on CB2 receptors. The two phytocannabinoids that have been extensively studied are the trihydrocannabinol or the THC and the cannabidiol or the CBD. So just remember THC and CBD. Now, nabiximol or Cetivix is an oromucosal spray containing a 1:1 combination of THC and CBD. Okay. And they are well tolerated with improved analgesia, particularly in opioid unresponsive cancer patients. Now, the preparations that are available, the ones that have THC dominant ones are the dronabinol. It's a synthetic THC. It's given by the oral route, and nabilon, that is also a synthetic THC. And the CBD dominant ones are the cannabidiol, which is a 99% pure oil, and that can be given in a dose of 5 milligrams per day. Or you have, like I mentioned, the oromucosal spray, which contains equal amounts of THC and CBD. So it contains of 2.7 THC and 2.7 CBD in each spray. But just remember, these are all drugs with a high potential for abuse. Now, the analgesic effect of cannabinoids are comparable to the weak opioids only. So after 15 to 20 milligrams of THC, the peak effect occurs in 3 hours and lasts up to 6 hours. So the dose of this is every 6 hours. So it can be used as a third or fourth line treatment for neuropathic pain when conventional therapies fail. Cannabinoids has also been used for chemotherapy-induced nausea and vomiting. And the ones that are used are dronabinol and nabilon, which are the synthetic THCs. Okay? I won't talk about that because that is beyond the scope of this particular talk. So the side effects of cannabinoids. The important side effects are the neuropsychiatric ones. That is, they aggravate pre-existing anxiety, schizophrenia, and depression. There could be impaired cognition, particularly because of the excessive sedation and impaired motor skills. There could be a risk of infection because it reduces the host response. And there could be cardiovascular side effects like hypertension, hypotension, tachycardia. So we must avoid in patients with heart disease. So what are the use of cannabinoids in palliative care? Can be used as an analgesic, as a third or fourth line treatment for neuropathic pain. It can be used to control chemotherapy-induced nausea and vomiting. It can be used for cancer anorexia, for HIV-related cachexia, for multiple sclerosis-associated spasticity, and it can improve the mood and antipsychotic effects in chronic illnesses. It also has anti-cancer activity, particularly because of its action on the CB2. Can be used for sleep disorders. Many people take cannabidiol oil for insomnia, and can also be used for, it can also cause seizures. Now, what is the current evidence? The recent study showed that medical cannabis had significant improvement in pain measures with a decrease in other cancer-related symptoms, and it reduced the consumption of opioid-based analgesics with the side effects are minimal. This was a recent study that appeared in Frontiers in Pain Research. So is use of cannabinoids legal in India? What is the current status? Now, we all know that abroad, it is being used not only for illnesses like multiple sclerosis and cancer pain, but also for recreational purposes, and it is legal for that. But in India, there was a petition in the Delhi High Court challenging the provisions of the NDPS Act. See, NDPS Act says that all kinds of opioids, including cannabinoids, are illegal. So this was challenged to the Delhi High Court that it should be legalized for medicinal purposes. And the center has informed the court that only this year, cannabinoids is allowed use in India for medicinal and scientific use as per the law, and it is not completely banned. So as of now, we can use it for medicinal and scientific use. Now, another drug that is very useful for refractory cancer pain is corticosteroids. Like I mentioned in my earlier presentation, it's useful. It's a multi-purpose drug. It can be used for neuropathic pain, bone pain, headache because of intracranial metastasis, and even for bowel obstruction. And the drug that is commonly used is dexamethasone because of its long half-life, only once a day dose with a potent anti-inflammatory effect with less mineralocorticoid effect. But they can cause insomnia, So it is always given in the morning, and particularly those with less life expectancy, it can provide the short-term relief of pain that they require. Now, GABA receptor agonists, we know that there are two types of agonists, GABA A, GABA B, out of which GABA A are the benzodiazepines, of which clonazepam is the one that is used for neuropathic pain, and GABA B receptor agonist is baclofen. Now, baclofen is effective for refractory neuropathic pain, and it can also be used for spasticity, trigeminal neuralgia, hiccups, and musculoskeletal spasms. You start in a dose of 5 mg, and you can increase it up to 20 mg TDS. I've talked about this earlier, but bone pain is yet another important cause of refractory pain. And there are a number of options that are available for bone pain, which include corticosteroids and NSAIDs, calcitonin, bisphosphonates, and denosumab, and palliative radiation. Now, malignant bowel obstruction, again, another important cause of refractory cancer pain, like in this case that we just discussed. Okay, so for this, we can use octreotide. It's a synthetic hormone. It is a somatostatin analog. How does it act? It decreases the splanchnic blood flow, decreases the portal blood flow, decreases gastrointestinal motility. The gastric, pancreatic, and small bowel secretions are decreased, and it increases the water and electrolyte absorption. It's given a dose of 300 mics in 24 hours as a continuous subcutaneous infusion for 6 days. And this organization, that is MASCC, has said that octreotide is a drug of choice for malignant bowel obstruction. It can be combined with steroids and hyoscine as well. So we now discuss all the various pharmacological options. So what are the non-pharmacological options for management of difficult pain? This I've already shown in my previous thing, that we have the step 4 options, which includes nerve blocks, epidurals, PCA pump, neurolytic therapies, spinal cord stimulators, intrathecal opioids, etc. So it has been shown we can use a PCA pump, nerve blocks, epidural blocks, neurolytic procedures, intrathecal opioids, spinal cord stimulation in those who have severe side effects from the drugs and whose life expectancy is more than 3 months. And if it is not responding to that, then you have central neurodestructive procedures like rhizotomy, gangliotomy, chordotomy, myelotomy, thalamotomy, cingulotomy. But these are very rarely done, only when the life expectancy is less than 3 months, and they are associated with very high risk. So the risk-benefit ratio should be assessed and the patient's told about it when you're planning these procedures. I've never seen any of these procedures being done because they are too risky also. The other non-pharmacological options include dry needling, acupuncture, biofeedback, psychological therapy, physical modalities, spiritual therapy, alternate therapy. So it is not, they are all given as a combined, as a multimodal kind of a therapy. Okay. Now, I've already mentioned about dry needling, and I think there was some query regarding dry needling as well. So this is how we use dry needling to treat muscle spasm and myofascial pains associated with severe cancer pain. Because very often, whether it is due to a spinal metastasis or even intra-abdominal metastasis, there could be a lot of spasm, and that can be treated by dry needling. The other physical therapy that can be used include ambulation and musculoskeletal therapy, the various agents like heat, cold, TENS, etc. And psychosocial therapy and spiritual therapies also need to be addressed in refractory cancer pain, because these people have a lot of fear and anxiety, depression, anger. So a lot of options are available, which include counseling, communication, medicines, support groups, and even providing financial support for children's education. These all can alleviate the psychological pain that these people are experiencing. Now, coming back to our case scenario, what was the cause of refractory intractable pain in that particular case that I discussed? Now, he was refractory to the domiciliary use of step 3 drugs. The causes could be medical causes, that is, either the disease has progressed, the colostomy site definitely looked unhealthy, or was there a failed route of absorption? Was the oral absorption poor, or since he was on a fentanyl patch, was there a decreased transdermal fentanyl absorption? Or did he have psychosocial concerns? So these are the various things that we should consider in that particular patient. What was done? He was readmitted to the hospital. It was found that the colostomy was non-functional, and that was obviously the cause for the severe pain that he was having. So a root conversion was done. So the transdermal fentanyl was started changed to a fentanyl infusion along with supportive care. And over time, a period of 24 hours, the pain subsided. End of life care was instituted, and this was explained to his relatives. He expired free of pain 2 weeks later. But have we been drug-centered or interventional-centered in our approach? What is the role of non-pharmacological options in this particular patient? What were the psychosocial concerns that this patient had? Now, he was a highly educated retired doctor. He had no financial concerns because the cost of his treatment was fully covered by his insurance. He had a very supportive family, a wife and a daughter. The wife was a main caregiver and had taken the role of the head of the family, managing all the medical and the financial aspects. But despite all that, he was depressed because he knew that there was no cure and he would not live long. He had a sense of hopelessness, helplessness, and powerlessness. He also experienced loneliness and isolation particularly because it was also the COVID times, they had withdrawn from friends and relatives for more than 2 years. He had a low self-esteem because he was totally dependent on his wife, even for self-care activities. He had a sense of guilt. His family had given up all their activities. Wife had given up her job so that she could be his full-time caregiver. And there was a role reversal as well, because he was the head of the family, but now his wife had taken over all his responsibility, including the financial aspects of their home. So when you look at this, we find that at every step of the ladder, step 1, step 2, step 3, there is the psychosocial aspects that need to be considered in addition to the drugs. And later on, you can go in for the various modalities, interventional therapies like intrathecal opioids or the implantable devices. And only in very, very rare cases, we can go in for the neurodestructive procedures. So if everything fails for providing pain relief, we can consider palliative sedation. Otherwise, we can accept the failure, but we should never desert the patient. We should be fellow travelers in their difficult journey of the terminal stages of cancer, where there is a lot of pain. We can be frank about the failure, but we should convey it with sensitivity. And the psychosocial, spiritual support should continue, and we should treat any worsening condition as well. That is the thing. Stop the screen share. Okay.
Thank you, ma'am. Now we can have the doubts cleared.
It is a very difficult topic, and there is no magic bullet in treating cancer pain. I mean, particularly difficult cancer pain. So you have to basically employ a multidisciplinary, multimodal approach. It may be oral or interventional along with the physical therapy, the interventional therapies, as well as psychological therapies. So it's all a combination of everything that can ultimately provide him some pain relief. If there are any questions, and I'll try and answer them.
So there's a question, ma'am, from Iral Media. What is palliative sedation?
Okay, I think that's a different topic altogether, and it will be addressed later. But you can use a drug, particularly clonazepam, for palliative sedation. You can use morphine for palliative sedation or fentanyl for palliative sedation. So clonazepam is quite commonly used for palliative sedation, but I think that will be covered at a later stage. That will be addressed by another speaker at a later session.
Dr. Apurva has raised her hand. Dr. Apurva.
Ma'am, could you please explain once again the morphine to methadone conversion?
Okay. See, in morphine, if you're giving, if the dose is less than, I just start that screen share, then you'll be able to see it better. Can I have the screen share, please? Oh,
Yes, ma'am.
share screen, correct. Okay. So this is a thing. If the patient is getting less than 60 milligram oral morphine a day, then you can give in a dose of 2 to 7.5 mg. These are all conservative estimates. So we do not need to reduce it by 50% or 25%, okay, because of the incomplete cross tolerance. If the patient is getting between 60 to 199 milligrams morphine per day, and if the patient is less than 65 years of age, then you divide that total morphine by 10, and you will get the dose of methadone. For example, the patient is getting, say, 100 mg morphine. Then you divide it by 10, that is equivalent to 10 milligrams of methadone. If the patient is more than 200 mg morphine per day or more than 65 years of age, then you convert it by dividing by 20. So if the patient is getting, say, 300 mg morphine a day, you divide it by 20, which is equivalent to 15 mg. There's no need to reduce it to account for the incomplete cross tolerance. Is that clear?
Yes, ma'am. Ma'am, just wanted to know a little bit more about the same thing, that what you're mentioning is between 60 to 199 mg when they're taking. Both the conditions have to be accepted, that is, which is the dosage plus the age also should matter. Or if at all the person is using 60 to 199 mg and is more than 65 years of age, we still continue with 10:1 conversion.
I think the patient is more than 65 years of age, is better to go for 20:1. I think so, but you can just cross-check it. Okay?
All right.
Because elderly people, we have to do the little more conservative doses.
Okay. Thank you, ma'am.
I think methadone was addressed in a previous talk. Was it discussed in strong opioids?
Yes, ma'am. I think we had sessions on methadone. The session. I think I believe Dr. Sunil has explained this. This was explained as a white paper consciousness, and he had done the math like cases scenarios also. So if anyone have any doubt on that, please feel free to contact us. You can upload your queries in the link provided. And
1 minute, Shripriya. Shripriya is there?
Yes, ma'am.
Shripriya, there was one query that had come, no?
Yes,
we
ma'am.
can talk about it right now if you want, if you have that query with you.
Yes, ma'am. Actually, one of the participants had specifically asked about dry needling. And I believe today also one doctor had asked that whether they can study.
Okay. So what exactly you want to know on dry needling? Or maybe I can send that later on, no, as a thing.
Ma'am, actually, the question was raised by Dr. G. Kamala, and we have her on this session as well. Dr. Kamala, if you could unmute yourself and just be more specific, what aspect you want to know more, Dr. Mary can definitely share it.
Ma'am, is it any specific duration?
Sorry,
How long
sorry,
should
Kamala,
we
can you
do?
just repeat that again, please? Yes?
Dr. Kamla?
Is there any specific duration? How long should it be given? Needling, dry needling, ma'am.
Okay. See, it depends upon the chronicity of the condition. If it is an acute pain that is less than 3 months old, then usually it responds to a very few sessions of dry needling. Maybe 2 to 3 sessions it can respond. But in chronic pain, when the pain has lasted more than 3 months or maybe a year or 2 years, then you may require more sessions, maybe 5 to 10 sessions. And usually we give it twice a week, and each session is for 30 minutes. That is, you keep the needles in situ for 30 minutes. And we give it usually twice a week only, not more frequently. And there are now workshops that are being conducted for dry needling. But what the physiotherapists do is a very different kind of dry needling. We don't follow that. As pain specialists, we have our own ways of dry needling.
How different is dry
Can
needling
we
from?
do, madam, or physiotherapist is needed?
Pardon me?
Can we give that dry needling or physiotherapy is needed?
No,
Physiotherapist.
physiotherapists don't do the kind of dry needling that we do. They just put 1 or 2 needles, whereas we put many more than that because we are going according to the muscles that are affected. So what they do is very different from what we do. Plus, being doctors, we know exactly about the problems with various areas of dry needling, whereas they are a little more apprehensive of dry needling. So they do very limited dry needling. We do more sort of wide dry needling.
Two more queries related, ma'am. How different is dry needling from acupuncture, and is there any side effects of dry needling for cancer patients?
Dry needling is it's totally different from acupuncture. Acupuncture believes that there are some channels in the body which surface at certain points, and because that energy is supposed to stagnate or it is going very fast, when you needle that surface point where it is coming to the skin, you're able to control that flow of energy. We don't believe in all that energy concept. We are going into the muscles. Scientifically, we know which are the muscles. For example, in the back, for backache, we know that it is a deep spinal muscles that are involved. So we go to the particular muscle, whether it is a multifidus or whether it is a longissimus. So we are going in a very scientific way according to the muscle anatomy. Okay. So we are not going, it is totally different. There is no comparison between acupuncture and dry needling.
Regarding
And no
steroid-
side effects, no side effects, provided you know what you're doing. Like you can't put a needle into the intercostal muscle and expect that you don't cause a pneumothorax. Okay. So those, but if you know where you're going, and if you're using ultrasound when you're using in certain vital areas, then you can prevent pneumoperitoneum or a pneumothorax or inadvertent arterial puncture or anything like that. But otherwise, if you're doing it in a proper way, then the risk of side effects, that's a good thing, because there are, when you're giving other drugs, then you produce a lot of side effects. This has got hardly any side effects. Occasional bruise can happen, but other than that, nothing, provided you know where you're doing. For that, you have to have a good knowledge of the anatomy. And if you're using in certain vulnerable areas like the chest muscles or the upper back muscles, then you need to use ultrasound as well. So that's called ultrasound guided dry needling. But when you're using dry needling for the low back or for the buttocks or for the lower limbs, then even ultrasound is not needed. Okay, a lot of questions on dry needling. Is it painful? Okay. So for that, I usually give an analgesic, an oral dissolvable analgesic 2 hours before. And we can also apply the EMLA cream, but very often I don't use that. And it is hardly painful because compared to the pain that they're having, this is nothing as compared to that. And but oversensitive patients, you can apply the Prilox cream or the EMLA cream in that particular area. But that is only providing sensitivity of the skin, whereas you're going deep into the muscle, right? So that will not provide any pain relief for the muscle part of it. It's only providing for the skin. So that's really not effective, but you can give an analgesic orally before doing the dry needling.
We have two queries regarding use of steroids. One, how long do you use steroids for difficult pain, and how do you manage its adverse effects?
Steroids, is it?
Yes, ma'am.
Steroids are given as a very short-term course, maximum 3 to 5 days. That's it. So that is why it will provide temporary relief. So patients who have got a very less life expectancy, they can provide some temporary relief of pain, but definitely we cannot prolong steroid for more than 3 to 5 days. So it has got a limited in the sense that it cannot be given indefinitely. So it is used for short-term palliation.
Dr. Dia has asked, can patient-controlled opioid result in overdose?
It cannot, because when you're doing a patient-controlled analgesia, you have a lockout period. So in that lockout period, even if the patient is giving, pressing the button, the opioid will not be delivered. So you have to calculate it and give that lockout also in addition to the basal infusion. So for the bolus dose, the lockout has to be put in so that in that lockout period, the pressing the remote also will not deliver an extra. So that way you can prevent overdose.
Dr. Shivam has asked, should we use morphine for BTP dose with methadone?
Pardon me?
Should we use morphine for BTP dose with methadone?
Breakthrough pain?
You
don't normally combine two opioids, but I think it can be used, but I'm not very sure about that, whether you can give morphine for breakthrough pain. But see, for buprenorphine and fentanyl infusion, you can give, their breakthrough pain can happen. You can give, like buprenorphine patch, 7 days it lasts. So in that breakthrough pain, it has been seen in the literature that you can give an immediate release morphine. But methadone, I think you can give it. I'm not very sure. Maybe we'll have to just check
We
it
have
out.
been using morphine for breakthrough pain for methadone.
Okay, so then it can be given, right?
What we usually use is when we switch a patient to methadone, we try to give it as Q4H as SOS. So every 4th hourly, we'll ask patient for pain. If there is a severe pain, we will give a morphine dose. So it's kind of an every 4th hourly, we ask for a pain score, and if there is severe pain, we'll give morphine. So it's an SOS.
But how much dose of morphine will you give?
Then like the patient, it will be equivalent to that, comparable to the dose of methadone. Like if the patient was initially on 5 milligram 4th hourly and we switch the patient to methadone, we'll keep 5 milligram itself as, and in time when the methadone dose is raised, we'll raise the rescue dose also accordingly. Is there any specific dose calculation of rescue dose opioid to manage acute pain crisis in patient already with opioid?
The rescue dose is equivalent to the dose that the patient is getting, right? So if the patient is getting 10 mg 4 hourly, the rescue dose is 10 mg, right? Is that the answer?
Dr. Vinandya? Dr. Vinodhi, can you unmute and clear? And there's another question. Can you explain about other non-pharmacological techniques which provide adequate pain relief in current scenario? Yeah. Dr. Shahina, could you be please more specific? Dr. Shahina?
Yes, sir. Actually, in addition to all opioids, what are the other ways of non-pharmacological techniques can be practiced in today's situation? In routine palliative care, what are all the non-pharmacological techniques can be included in a best way? I wanted to know.
Are you talking about interventional pain management?
Apart from interventional,
Okay.
other
Okay.
pain management.
So, things like the posture of the patient, like for example, the patient has got, radiculopathy because of some spinal metastasis. Then the way the patient is lying down with this, support under the knee, so that the leg is not stretched. So posture, positioning of the patient, and maybe things like hot packs or cold packs, okay? Or
Ma'am, if the patient wants to try to walk or he wants to do some kind of activities, is it possible for him to carry out such mild activities?
you can give an additional dose of morphine, an immediate release dose of morphine, because that additional activity can cause an incident pain, right? Breakthrough pain. So you can give some medicine for the breakthrough pain and then allow them to do that activity.
Okay.
Say morphine, you give another tablet, wait for half an hour, and then he can try to walk a little bit.
Okay.
Or if you have a fentanyl lollipop, you can give that to him. That also acts within half an hour, and then he can do that activity. So you may have to do something to enable him to do that activity.
Yes.
So physical therapies, like I mentioned, heat, cold, or the positioning of the patient, or all these things can be definitely used to go.
Any kind of relaxation he can get, ma'am, like as through some breathing exercises, some other yoga practices. Will it help him?
Yes, definitely it will help him. Maybe massage can help, Ayurvedic massage, massage therapy is very good. And oil application of some oils, Ayurvedic oils, and some, or some gels, a lot of analgesic gels are available. That also can be applied. Yeah. So you have to use a lot of these non-pharmacological options.
Yes. Okay. Thank you so much.
To add on, I think I have seen a few patients benefiting from the help of a psychologist, like image guiding issue. So what that is, the psychologists help them to image something, a scenario, and go through them. So it acts like something like a distraction therapy. So it might happen.
Yeah, psychological therapies are very, very useful, cognitive behavior therapy, acceptance commitment therapy, the patient is made to realize that everything is not negative. So the thoughts are changed so that their behavior changes and their mood will change. So because there is this gate control theory of pain, right? So in the gate control theory of pain, even anxiety and inactivity, lack of physical exercise, depression, all of that is opening the gate so that the pain impulses are allowed to pass through. Okay. So when you do all this distraction therapy, massage therapy, or TENS is also very good. then you're actually closing the gate to the pain impulses going up. That is a gate control theory of pain. So gate control theory of pain is also taking the psychological aspects into consideration.
Thank you, ma'am. I think we have one more query. So diagnosis of opioid, how do we diagnose opioid tolerance? At what dose? Is it subjective to the physician? If changing to methadone due to tolerance, will the calculated dose for methadone be high?
I've already talked about the calculation, no? Changing from morphine to methadone. Okay, so they have like fixed dose between up to 60 to so much, between 60 to 200 is so much, and beyond 200 is so much. So based on that, you have to calculate the dose of methadone. What was the first part of the question?
How do we diagnose opioid tolerance?
Opioid toxicity or tolerance?
Tolerance, and at what dose?
Tolerance is that when you have to keep on escalating the dose of morphine very fast, because the patient has developed tolerance. Then you realize that patient is developing tolerance, and you're going to, as you go higher and higher, the signs of neurotoxicity will start appearing. So that is when you realize that you have there's a ceiling and you can't go beyond that. See, when tolerance happens, you have to keep escalating the dose of morphine, right? As you're escalating the dose, initially it will be all right, but at some point, neurotoxicity will appear because of the metabolites, toxic metabolites. And that's when you realize that you can't go higher than that. Because of tolerance, only you're increasing the dose of morphine each time. But at a point, a ceiling is reached when you start developing symptoms of toxicity, and then you cannot escalate it further. Then you have to consider a morphine rotation.
So it's subjective more to the patient, not to the physician.
Yeah, yeah.
Another is methadone used in diabetic neuropathy?
Yes, because diabetic neuropathy is, the pain is neuropathic in nature. But if it is diabetic neuropathy due to non-cancer reasons, there's a big controversy about how much of these strong opioids can be given for non-cancer pain. So generally, we don't give it for non-cancer pain. Cancer pain that is neuropathic in nature, we can give methadone. But for non-cancer pain, we really have to take a call whether we can give strong opioids. I'm not comfortable using strong opioid for non-cancer.
I had instances when I had to use opioid for non-cancer pain, methadone for non-cancer pain.
Okay.
There's a spinal cord injury patient who had no relief from any other medication, but severe pain. But he didn't have much relief, and then he at last went for interventional therapy. Only with that he got relief. So one more question. If a patient already given morphine sustained leads 20 milligram PD, I have read in a literature that the rescue dose should be 1/6 to 1/10 of total daily morphine. What do you think about that? So
I'm not sure. Can you answer that?
Patient is on sustained release 20 milligram twice a day. That's 40 milligram per day.
Yes.
And the literature says the rescue dose should be 1/6 to 1/10. So what do you think about that? So the patient on whole leaves 40 milligram, 1/6. So what we usually practice 1/6 to 1/10. I will agree with that. We usually prefer to give 1/6 of the total daily morphine as rescue dose. So this patient can be given like 40/6. I'm not good with math.
So you have to give 40/6. That is 6 milligram morphine.
Almost 6 to 7 milligram. Or you can go for 5 milligram tablet. Yes, 5 milligram tablet will be available. Dr. Harsha says WHO step ladder is for cancer pain only, or it can use for chronic pain also.
It can be used for chronic pain, acute pain, and also cancer pain. Even for acute pain, you can give. Acute pain means I'm talking of pain due to operations, post-operative, or due to trauma, or due to any fractures or anything like that. You can apply the WHO ladder for that also. And very much we use it even for chronic pain.
Thank you, ma'am. I think we can move on to the case presentation for the day. Dr. Harsha, may I invite Dr. Harsha for the case presentation?
Yes, sir. Good evening.
Dr. Harsha, you are audible. You can start.
Good evening. I am Dr. Harsha Bhutra. I am an anesthesiologist working here in Surat. Now, my case is a 62-year-old female. She was operated case of spinal cord compression around 3 years back. She, next slide, please. She came to me with severe pain here in her lumbar area and right leg. Actually, I talked with her today only, and she said that she is having numbness on both her legs as well as on both her arms, upper limbs also. She had pain while walking 4 years back, so she got her right knee replacement done 4 years back. Symptoms persistent, and MRI spine showed that she had cord compression at L2, L3 and L3, L4 space. So she underwent laminectomy, and a tumor was found, and it was removed from the lumbar spine. But post-surgery, her pain continued and she was unable to walk without support. Her physiotherapy for muscle strengthening was started, but she didn't have much pain relief. At present, she is confined to the 4 walls of her house, and she cannot sit and stand for a long time. She walks without support at home, but it is very painful, and she requires a stick to walk when she is outside. She was on medications for around 3.5 years for the pain, but she is now dissatisfied with that, and she is irregular with her treatment. She presently came to me for intractable pain and was unable to do her activities for her daily living. On examinations, her vital were normal. Pulse of 80 per minute, BP was also normal, and her local examination showed there was a scar of laminectomy in the lumbar region, and spinal tenderness was present at palpation, and there was pain on movement of the right lower limb. She was started on pregabalin 75 mg HS along with paracetamol 650 mg TDS. And she was advised physiotherapy for her muscle strengthening. And she is not regular with her medications, and she is very frustrated because she has constipation associated with pregabalin. So she takes pregabalin only once in a week, and she is not continuing it for a daily basis. And she does the exercises at home. She came to me last 15 days back, and I advised her that you start with pregabalin at least alternate day 75 mg at night, and start with a drug for constipation. So she started with Clemafin, and I spoke to her today morning. So she said that I am feeling a little better with pregabalin HS dose, and now she has escalated it to 75 mg means each night per day. Next slide, please. She was a receptionist before this, but due to the pain and discomfort post-surgery, she could not continue with her job. So, and she's unable to sit and stand for a long time. And so going out is difficult for her, as she requires some assistance for the same. So if she has to go out somewhere, either her brother or her sister-in-law, she has to accompany her even going to the hospital. So she is confined to her house and is dependent on her brother and sister-in-law for everything. She was a very social female before this operation, but she has no option but to be at home. So she is very disturbed socially also, and her relatives are very supportive, but she cannot go out for anything. So like she was started on pregabalin 75 mg HS and syrup Clemafin 5 ml OD. Paracetamol was started 650 mg TDS and was advised regular back and lower limb exercises. I counseled her that you continue for the treatment at least for 1 month, and let's see the difference. So today it is almost 15 days after that. And today I spoke to her. She said she's a little better with pregabalin, but dissatisfied with the constipation. Next slide, sir. So the main concerns here are that she has persistent pain and decreased mobility. It has been since 3 years. She cannot socialize and she cannot do her daily activities. Due to this, she is very dejected and frustrated. And she has been going from one doctor to another. Actually, she's doing doctor hopping, and no one is able to help her. And she's concerned about the cremafin syrup, that she has the feeling that cremafin may cause her diarrhea. And due to that, because she has decreased mobility, she may not be able to go to the washroom fast, and her clothes can get soiled. So she is reluctant to take cremafin. Next slide, sir. So I just want to discuss what else can be done for her pain relief and how to improve her daily life. Like being a busy person, now she's completely at home. So what all can be done and how to counsel her about the condition. And like someone asked just now, I also asked during the discussion, can we start her on opioid? Because I felt that opioid is generally to be started for chronic cancer pain and not for the other conditions. Thank you.
Thank you, Dr. Harsha. So let us listen from the others. What are the inputs from the team? What else can be done for pain? And Dr. Harsha has raised one question: can we start opiate for the pain?
Harsha, one question I had is, how old is this lady?
Sir, ma'am, she is 62 years old.
Is she married? Does she have a family?
No, she is not married. She is staying with her brother and sister-in-law. She is unmarried.
So basically, she had a tumor in the spine at the level of the lumbar region, which
Yes,
was removed, right?
Yeah, but her MRI later on showed that she has lumbar canal stenosis, and she had some problem in the cervical region also. So, matlab, she has numbness in her upper limbs as well as her lower limbs.
So the question about starting strong opioids is, why don't we give her the full benefit of step 1, step 2 before moving on to the opioids? See, we don't have to jump the gun, right? So we have to first give her the full trial of step 1, step 2 drugs with adjuvants, and then only we should consider the strong opioids. No? So we have not been added a tramadol or a tapentadol for her, which is a step 2 drug. We can further increase the adjuvants to maybe adding a muscle relaxant, because what she has is something like a failed back syndrome. That is, the operation has been done, but the pain is persisting. So it is called a failed back surgery syndrome. So for that, there are a lot of muscle spasm that is causing the pain as well, and also the lumbar canal stenosis, which is there. So we need to give, maybe move on to tramadol, or maybe add a non-steroidal anti-inflammatory drug. We are giving only paracetamol. So we have to add that. Then we can add a muscle relaxant as well. And we can also add an antidepressant to the anticonvulsant, because she has got numbness. So you can add an antidepressant as well. Unless we give the full trial of all this, why do we want to move to morphine? That is my question. And also, the pain could be, she's so apprehensive. She's even apprehensive of taking a laxative. So a lot of reassurance is required. She's depressed. So for that, we may have to add something. How's the sleep? Is she able to sleep well?
No, she is not able to sleep comfortably.
Yeah. So that is why I'm saying that antidepressant will also help in her sleep. Or maybe you have to add a sedative for the sleep. So we have to add more than one adjuvants for her. And also more than one analgesics also. The paracetamol is right at the bottom. We can add maybe a non-steroidal anti-inflammatory drug, or maybe move on to tramadol or a weak opioid, and give all these adjuvants before we can think of morphine.
Okay. Actually, ma'am, she was going to a orthopedician before she came to me 15 days back. The drugs which were there were prescribed by the orthopedician to her, and they also started with baclofen 3 years back when she was operated. So she was taking baclofen till around 2-3 months back, but she felt that it is of no use to her. It is not relieving her pain. So maybe because not the step ladder is not been followed, she may be having that continuous pain, and it has caused mental depression in her, and which may be aggravating her pain.
Yeah, definitely. We have to treat her depression and her, anxiety about so many things she is anxious about. We have to do, she needs counseling, and she may need change of these medications, like I told. And also, one good thing that you can do for her is dry needling, because after spine surgery, there's invariably a lot of spasm of the low back muscles, and that can respond very well to dry needling.
Okay, ma'am.
I've treated many patients of failed back surgery with dry needling.
Okay, ma'am.
Because there is a neuropathic element as well in her.
Yes.
So we need to give the full benefit of the anti-neuropathic treatment by adding an antidepressant as well, like amitriptyline or nortriptyline also to the pregabalin.
Dr. Harsha, were you able to assess the severity of her pain? Make a score or use some tools to?
No, actually, sir, I met her just before we started our class. So I didn't do the pain score in her, but it was just a verbal communication. I didn't do the pain score, but next time when I meet her, I'll make sure that her pain score is recorded.
But if you ask me, in this patient, I would not give her morphine.
Yes, ma'am.
Yeah, because we have to give, so many other options are there before we go.
I agree, especially in non-cancer patients starting an opioid, which has long-term issues.
Because this will be, she'll be taking it for so many years, and tolerance will develop, and so many other side effects will develop.
Yeah.
She'll get more constipation also in addition.
She's already done with the constipation. Constipation is preventing her from taking medications.
Yes, yes.
So I would definitely suggest to, as ma'am said, look for other interventions possible, or step 2 medications, assess for response. And only after that, if there are no other way and if she is in severe pain, we can think about step 3 opioid. So, and constipation also has to be relieved. She's really constipated, that would also add to her pain. So how to improve her daily life? Dr. Harsha, what do you think we can do to help her improve her daily life?
Sir, I think that she should engage in some activities, and if we give adequate pain relief, she may be able to go out or make a social circle, or go in her complex and meet some people. So maybe her daily life can get improved. And if you start with laxative, so if her constipation gets relief and the pain relief is gone, she may feel a little better.
So what the other team members think about this?
Can we have the gallery view, please? Then we can everyone see everyone. Yeah, now we can see people talking.
She can go in for a part-time job instead of full-time job, madam.
Yes, yes.
So that will.
Yeah, before that, we have to provide some level of pain relief before she can think of all that. So I think we should do a lot of titration of the medication that she's on, start other modalities as well. And then she should definitely get back to her job, because the occupation and getting back to work is very important for patients with this.
Any more inputs? Dr. Tino, do you have any other inputs?
Just to motivate her to take one day at a time. It's very much necessary. And we have to actually, as the first slide said, we have to believe the pain. We just cannot, take it as a materialistic thing. Ki, you take the meds, you'll be all right. So we have to believe in the patient and whatever she says and try to provide comfort apart from the medicines. And just take one day at a time.
Basically, we have to do a total pain management for her.
Yes,
okay.
Yes, exactly.
We have to treat her physical part. We have to treat her psychological part, her social part. Everything needs to be addressed. Only then you can provide some
yes, ma'am.
breakthrough for her pain.
I believe this is a place where multidisciplinary team has to act. Like we can use the help of physiotherapists, occupational therapists also, so that her activities can be improved with some modalities that they can offer, like a good seat, where she could sit with proper back support. Some instruments that she can use to facilitate their work, even at home. So that's somewhere we can get multi-team for the benefit of the patient.
Harsha, another thing, when you examine the patient, just examine, you said there is spine tenderness, right? But also try to see the paraspinal area, the area above the iliac crest where the quadratus lumborum is there. Look at the gluteus. Very often you'll find that the gluteal muscles are very tight. What about the hamstrings? What about the calves? All that you must feel to see whether there are any tender areas. Because it's not just low back pain, but you'll have to see the entire, because the L5 radiculopathy will include the hamstrings, the gluteus, the calf, everything. So the whole myotome has to be checked, and if it is there, then definitely dry needling will help in this.
Next question is how to counsel her about her condition. Dr. Harsha?
Sir, actually, when she came to me, she was very dejected. कि मैं इतने डॉक्टर्स के पास जा रही हूँ और ट्रीटमेंट हो रही है, पर 3 साल से मैं एकदम परेशान हूँ. So what I did is I just counseled her and I told her that you are not regular with your medications. You should at least start with some medications which are regular. If you take the dose only once in a week, which is to be taken daily, so your blood levels will not have that adequate dose of the drug. So because of that counseling, she at least agreed to start with pregabalin daily, and she was concerned about her diarrhea, which I told. So she used to put in castor oil in her umbilical region and said, "मैं हरी सब्जी खाती हूँ, so that relieves." But I told that you should continue with Crimafin. I think if your pain is reduced and if you are taking Crimafin, so you will be able to go to the washroom and you won't have that much of diarrhea that will soil your clothes. So she at least agreed to that, and she's started with that, and her pain has decreased a little.
She needs a lot of reassurance also.
She is a very anxious patient because since 3 years she has been suffering a lot, and before that she was very active, like from morning till evening. She used to work in the hospital. Actually, she was a receptionist at our hospital only. So like that, I knew her personally, but I never went into her details of the treatment, what was happening. So, but because of this, I thought that I'll just go to her, I'll talk to her, and then maybe we can help her with something. So I went to her to ask about all the details.
Suggestions from the team? Dr. Nirali, can we have some input from you?
So I was just thinking that for this patient, reassurance is needed. But how do you counsel somebody who is on chronic treatment, who is on and off her medication? Sometimes even I get certain patients who have rheumatoid arthritis or osteoarthritis, and they come with flares, and it's really hard uh, to tell them to be compliant with their medication. So if somebody can just in their experience share, obviously we don't have a script. Okay, chalo ye, we say this to the patient and everything will be all right. So if anybody can share their experience as well on to how to counsel such chronic patients.
Thank you, Dr. Nirali. So, Dr. Nirali has raised a question. Who would like to answer and help the entire team with this?
Part of the answer which I have figured out in my clinical practice is to be honest with the patient with the diagnosis. I know in our culture it may be something out of the norm, but you will get a better result and better compliance if you just honestly tell them that it's a long haul. It's not like for lifetime, but definitely it's going to take a while, and it'll be easier if you stay compliant with the medication. And this goes also for my hypertensive and diabetic patients as well. So I think a part of that answer, which I figured out for myself, was that okay, if you are honest with the patient that this is the condition, this is where we are, building a rapport with them also helps.
Yeah, I think that's very correct, that we have to be honest. We have to set realistic goals. But at the same time, you can tell them that we will try our best to try to relieve your pain. But you have to be compliant with what we are trying to tell you, and we will treat everything according to the side effects or whatever. And the main thing is to establish rapport. What you said is absolutely right. Once you have rapport, you won't believe half the job is done. And they may actually get relief by just knowing that you are there in their journey. And that's very important, having empathy with the patient, and setting, cannot promise the moon saying that he ko jayega and all that kind of stuff. You say that this is a difficult thing, but we are with you and we will try our best to try to relieve your pain so that you can do your activities as far as possible. We have to be honest and not set unrealistic goals. That's very important. More than anything, establishing a rapport with the patient is very, very important. I had a patient just last week. Her main problem was burning mouth. She had severe burning sensation all inside her mouth, on her tongue, the whole buccal mucosa. The pain was, she's saying, more than 10 out of 10, continuous morning and night. She's not even able to drink water for the last 1.5 years, not able to eat food. So it is really a difficult thing, and I cannot tell her that you will become all right. But I told her that we will try our best to try and make you get better, and try to treat. She's crying also. Her daughter was crying. Her husband was also in tears. But the whole family is upset. Now, in such a patient, you cannot tell a goal that you will become all right. We'll say that we'll try to make you as much possible, but just listening to you, and if they can realize that this doctor is going to do something different, they will get a lot of assurance.
Okay, ma'am. So being honest with the patient, so letting them know, and always explore what the patient know about their diagnosis and their prognosis. Explain it to them honestly, entirely, and in their own language, so that they can have a full understanding of what's going to happen, what's happening with them, and what's going to happen. And even the drugs that you prescribe to them, you tell them about the adverse effects and how it can help them. So a clear idea about what's happening would be helpful for the patients also. And regarding
the other thing is the patient should be positive towards your treatment. If the patient is going to be skeptical, saying that it is not going to work, believe me, that is, it'll really be a hurdle for the patient. If the patient is confident and positive towards the treatment you're giving, it makes a lot of difference. I never believed in it till I recently experienced it. I thought this positivity is all bunk, but it is, believe me, it's true. If they feel that this treatment is definitely going to help me, it acts by the gate control theory of pain again, that positivity is also very important for the patient.
And
Sorry,
when
I'm sorry to
no,
interrupt
no,
you.
please. So another one thing, when a patient comes with poor complaints, I would like to explore them why they have a complaints issue. I always do that in my practice, and I ask them what happened, why they are not taking the medicine. So there could be multiple issues. They may not be able to afford the medication. They might be afraid of the medication. So adverse effects. So many will be thinking someone would have told them, someone nearby their home, or some friend would advise them, you take pain medication, your kidney is gone. So that's something that
Yes.
they'll be fearing, and they would be avoiding the medication.
Yeah, exactly. Yeah. So we should find out what is the reasons for their non-compliance.
So I think Dr. Harsha has covered that part.
Hesitancy in taking medicine.
Yes.
We have to allay those fears,
Yeah. I think Dr. Harsha has cleared that part. She has asked why, and she had said that it's a constipation. The adverse effect of the medication is causing this. There we can help her with the laxative or remedies for that, so that she is okay to take the medication. We can get her into her path. Anybody, anything else?
I'm Dr. Veena. I wanted to add one point. Now, this patient is Dr. Hopping, as Dr. Harsha said. So she must be going to one doctor, maybe naturopathy, one homeopathy. So she will have one packet of naturopathy, one packet of homeopathy, one packet of allopathy. So patient is completely confused. Nothing is giving her relief. So she has stopped everything and she has devised her own medications of taking this alternatively and some castor oil here and applying. So that has to stop, and she has to stick to one doctor and set goals of therapy with that doctor and continue taking treatment of one form, or at least one place with the probably a team of doctors at one place who can help her. So that is one thing I feel is important than doctor hopping.
But at the same time, alternate therapies can also be mingled with your therapies.
Yes, ma'am. Yes. That's what.
There is a role of alternate
therapy. Yeah.
There's a role
Yes,
of
ma'am.
alternate
That's what I
therapy.
meant. Yes. Than getting confused with all, maybe someone who can combine everything that she is willing to take or what is helping her. That's what I mean.
There is a role for getting trust for the patient. You get the trust patient, make a good rapport with them, and she gets to understand that you're by seeing you she gets a better relief. She'll definitely come to it. But it will take time. It won't be always successful. We have to try. And as ma'am said, alternate therapy does have much value for them. And she will definitely go for them. She's in severe distress. She will definitely go for some relief where she'll go to someone from some medicines or indigenous medicines. Someone says that it's going to help her. She will definitely try.
She'll definitely.
We'll have to convince her. Thank you, Dr. Veena.
Hello.
Yeah.
I want to say that I think we are supposing, we don't know why the patient is changing doctors every time. We should ask him and know why he's doing such things. Okay, thank you.
Thank you, Dr. Christine. Any more inputs from the team?
I believe that this patient might be going from a doctor to one doctor to another doctor because she hasn't had an adequate pain relief. And the reason why that could be is because of there wasn't a stepwise treatment plan made for her, which she could follow. And maybe also the initial doctor treating her could not build that kind of confidence with her that this is what needs to be done. It is for a long time. So that's why what I have experienced in my practice as well, that mostly the patients go from one doctor to another doctor when they don't have enough information regarding their treatment or regarding their disease and prognosis. Um,
Yes, I agree.
Actually, I think that in India, the scenario is we don't have many medicine means physicians who do a holistic approach. Like what I have learned joining here since 1 week. Here at my place, before this someone used to ask me, someone who is good in palliative care, do you know anyone? So I don't have an answer for that. So we need to develop a team where people use holistic approach to treat any patient. She used to go to an orthopedician. He was focused only on her orthopedic part. Like, हाँ मैंने surgery कर दी. Now the pain part, you take this, go. They are not very well versed with what is to be done and what is the next step. So ideally, we should develop a network of doctors so that they can refer the patient which they cannot handle to someone other person who is actually able to help the patient. That was the problem with this patient, at least.
That's a problem with most patients. They are each one specialist is focusing on that particular thing, and they're not looking at the they're looking
patient
at the disease
as a whole
and not the person.
So the first day when here they taught that palliative care is about not about the disease, it is about the patient as a whole.
Yes.
That was what struck the idea, that you should actually see the patient as a whole and not as a disease, like the spinal cord and laminectomy and the patient is gone. You should not do that.
Yeah, I think we have exceeded the time. I think we end that session.
It was a good session, ma'am. Thank you.
Inputs from everybody mattered.
Dr. Arjun, I think you're muted.
Sorry. Thank you all. Thank you, ma'am. Thank you for the great session. And thank you for all the inputs from the team. So let's meet for the next session. Have a good day. Good night.
Thank you, Dr. Mary Abraham. Thank you so much. As coordinators, I think some of the sessions we do have the guarantee, the perfect guarantee that this session is going to be fine. And of course, Dr. Mary's sessions are one of those, because you can never go with any queries unanswered in her sessions, most of the sessions. Thank you so much for another wonderful session like that, Mary ma'am. And we do look forward to have you in more sessions in future. Thank you everyone for joining in. Today's session was really interactive with more participants coming in with their viewpoints. Please do continue that as we move along and learn palliative medicine and incorporate those in your areas of practice. So with a promise that we will be meeting again in the next session with another different topic and yet another eminent faculty. This is Sri Priya, along with Dr. Mary Abraham, Dr. Arjun, and Mr. Anup signing off from the Tips Hub. Till the time we see you again, take care, be safe, be happy. Bye-bye.